Good afternoon, ladies and gentlemen. For the next 15-20 minutes, I'm going to talk about another non-renal indication for renal replacement therapy, meaning ultrafiltration for acute heart failure. These are my current disclosures. So why should we be studying heart failure to begin with? There are three reasons at least that I can come up with. One of them is that congestion is the major reason a patient with heart failure comes to the hospital. For those who were in the session this morning, they know that I went through it quite a bit. Just to remind all of us, because we are nephrologists or intensivists, most of us, we see the patients where they are in cardiogenic shock. So we think that a patient with acute heart failure probably is a patient who has hypoperfusion. But major database studies have shown that the mean blood pressure of a patient who comes for acute heart failure is actually somewhere around 120 or 80. So congestion is the main reason a patient with heart failure comes to the hospital. Diuretic resistance is very common. The definition we are not yet sure about, but we know that many of our patients do not respond the way we want to diuretics. And then, as opposed to many other non-renal diseases that are associated with congestion, in heart failure, we have quite a few randomized controlled trials. For example, in burn patients, we don't have any, or let's say in liver disease. But we do have in heart failure, so it makes it a very great model to study the role of ultrafiltration in fluid overload. Well, these are some metrics and statistics about heart failure. Obviously, I'm not going through all of them. It's just meant to remind us that heart failure is the major reason for patients over 65 to come to the hospital. So tonight, in Vicenza Hospital, the majority of patients that are going to be admitted, they are having the diagnosis of heart failure. It is really common. And not only it is common, it's a major financial burden on the society. So it is a public health problem. Currently, how well are we doing the decongestion? The patients are coming for signs and symptoms of congestion, and our job is to remove the excess fluid, right? So this is based on ADHERE database, over 50,000 patients. So it practically reflects the common state of therapy of heart failure. It tells us that, and I apologize, these numbers are in pounds. You divide it by 2 and it becomes kilogram, roughly. So it tells us that 33% of the patients, 1/3 of the patients come to the hospital for decongestion, yet they only lose 0 to 2.5 kilogram of their weight and they leave the hospital. The problem is not even there. 16% of the patients come for congestion, they gain weight while we are treating them, and then they leave the hospital. And if you put all of these together, you'll see that nearly half of the patients are coming to the hospital. They either are not well decongested or they even gain weight and leave the hospital. So it wouldn't be surprising for all of us to remember that this heart failure has a readmission rate of 23% at 1 month. Basically, 1 out of 4 patients that will be discharged today is coming back to the hospital for the same reason within the next 30 days. So now that we know we are not doing really great with our decongestion strategies these days, what options do we have apart from diuretics? This is a figure of how heart failure is giving us renal dysfunction. The main reason I put it here is to mention that congestion is not just a sign or symptom. Congestion is like renal disease. It has bidirectional relationship with both the heart and the kidney. It's a major player, it's a dynamic state. So if we can take care of it, let's say with mechanical extraction of fluid, ultrafiltration, we might do something to break this circle. These are the proposed advantages, and I write proposed because some of them have not been very proven really. Just based on mechanisms, we thought that they probably will be the advantages of using ultrafiltration in this setting. I cannot go through all of them, but I just want to mention one, which for most nephrologists and probably cardiologists is the most important one, and this is the higher mass clearance of ultrafiltration. Remember, ultrafiltration is as isonatremic fluid is taken out. So if my serum is 140, in the ultrafiltrate, I will have 140 millimole per liter of sodium, while the diuretic that is generated by loop diuretics has between 60 and 80 millimole. So this one is really better at removal of sodium, which is the main determinant of extracellular fluid. So that would be a major advantage, right? And we'll get back to this a little bit later. Let's look at the clinical trials now that we know, or at least we think, ultrafiltration has advantages over use of diuretics. This is UNLOAD trial, a major trial, not probably, actually I should say, the largest study in this field was done nearly 11 years ago, the largest study that was completed, and we will get to it a little bit later. So 100 patients on the ultrafiltration side and 100 patients on the diuretic side. And for those of us who are used to having thousands of patients in cardiology trials, we should remember that this is an invasive therapy against furosemide, cheap, available everywhere. So recruitment is an issue in most of these trials. Anyways, so multi-center, 100 on the ultrafiltration side, 100 on the diuretic side, and this is what they found. Ultrafiltration is taking more fluid compared to diuretics. And this increased efficiency is not at the cost of worsening renal function. The red is ultrafiltration. It seems that there is a little bit of increase in creatinine actually most of the time, but the author said that at all times the p-value was insignificant. Interestingly, the secondary endpoints were very, telling. You know, the patient is getting ultrafiltration here and then is put back on his medical regimen, goes home. 90 days later, the patients who got ultrafiltration were doing better compared to those who had diuretics. They came less often to the hospital. And a number of other secondary endpoints also seem to be favoring ultrafiltration over diuretics. Well, another trial came out, which is the CARES heart failure, and this is the only NIH-funded trial in this field. This is stepped pharmacologic therapy. It is stepped, meaning that they did really robust design how to give diuretics to these patients. It was really nicely done. And ultrafiltration, 92 patients, 94 on this group. And remember that these patients were not only acute heart failure. These patients with cardiorenal syndrome, meaning that 90 days before to 10 days after admission, they should have worsening renal function. So it was cardiorenal syndrome. This is a bivariate endpoint. Interestingly, this is the change in weight, and this is the change in creatinine. Both interventions resulted in the same weight change as opposed to UNLOAD. So ultrafiltration was the same as diuretics. But the problem was that ultrafiltration was associated with more worsening of kidney function, or let's be more precise and say increase in creatinine. Okay? So this was not associated with any change in the outcomes in terms of, let's say, this is the rehospitalization, for example. So if we look at UNLOAD and CARES, it's interesting. UNLOAD did a great customized ultrafiltration regimen versus a diuretic that was left at the discretion of the cardiologist. Sure enough, the one that we did well won. UF did better. In the CARES heart failure, however, we did a suboptimal ultrafiltration. We had a fixed ultrafiltration rate of 200 milliliter per hour for everybody, no matter how congested they are, versus a stepped pharmacologic therapy that was very well designed. So this time we did poorly on ultrafiltration, we did great on the diuretic. Sure enough, the diuretics won. So we saw that we needed a fair comparison at this point. It was in 2012, it was published in New England Journal of Medicine. This came avoid heart failure. Avoid heart failure learned some lessons from the previous studies. This is bigger than the unload. It has 224 patients. However, it was not completed because the investigators were aiming for 810 patients. However, the sponsor, after some time, felt that the recruitment rate was not as high as they wished, and so they stopped the trial. So please bear in mind that when we are looking at the results, these are the results that might be underpowered, this study, because it was meant to have 800 instead of 224. Okay. So this time, again, it is acute heart failure. It's not cardiorenal syndrome. And before I go, let me say that this is adjusted loop diuretic versus adjusted ultrafiltration. So now we learned the lesson. We need to do them well and compare them. This is not meant to be read. It is meant to tell us that there is a great detailed plan for diuretic therapy, which actually we have used to suggest this is how diuretic therapy should be for heart failure, regardless of this study. We think that this is a great regimen for any patient with heart failure. And this one is a detailed plan for ultrafiltration therapy. This is what they found. They found that ultrafiltration is doing better than the diuretics. The diuretics are not as good, but remember, the p-value is not significant. Keep that in mind. The trend is there, but it is not significant. And it starts nearly a week after they have started. These are the secondary outcomes, and as you see, most of them favor ultrafiltration again over diuretics. What about the impact on the kidney function from 24 hours all the way to 90 days later? They looked at the kidney function in terms of serum creatinine. They couldn't find any difference between the two groups. So improved efficacy is not at the cost of increasing creatinine, basically. Interestingly, just earlier this year, meaning 5 years after they had done the actual study, they decided, let's take a look at the per protocol analysis of the same trial. Instead of intention to treat, let's look at every patient and see if he was assigned to ultrafiltration, what happened, rather than just going for intention to treat, right? This is just 5 years later. They remembered it's a good idea to do it. So the number of patients obviously comes really low, 76 in the medical therapy versus 30 in the ultrafiltration. And guess what? They found the same result that other studies had shown. There is better efficacy for ultrafiltration compared to diuretics if per protocol analysis is done. Remember that per protocol analysis has its own limitations. For example, the rule of randomization is kind of broken. So take it with a grain of salt. And it is for fluid loss and weight loss at the same time. Ultrafiltration, again, seems to be more efficacious. Another interesting finding in this study is here. We know that high-dose diuretics will give us more electrolyte abnormalities. Everybody knows that. Hypokalemia will be more common with diuretics, high-dose diuretics versus ultrafiltration, because ultrafiltration, again, takes the same concentration of potassium out, so the serum potassium is not supposed to change. So for potassium, there was no problem. We knew that the pharmacologic therapy will be associated with hypokalemia. But one thing that we don't understand is that why the ultrafiltration is associated with hyponatremia, actually. This, again, did not impact their outcomes in terms of rehospitalization or death. They are the same, but we keep that in mind that ultrafiltration shows some kind of signal for giving us hyponatremia. And then we remember that actually the year before, a group had looked at this, and this was the per protocol analysis. No, it was the intention to treat. They had gone back and looked at the sodium of the patients, and they had reported the same thing, that around day 4, you will see a major drop in serum sodium of patients who are having ultrafiltration compared to those who have pharmacologic therapy. And this is at the same time that actually the creatinine shows a little bit of a bump, as well as plasma renin activity, giving us a signal probably it is a neurohormonal effect. And actually the authors in that paper argued that probably the ultrafiltration group has had an excessive fluid removal leading to neurohormonal activation, and AVP has been active. That's why hyponatremia happened. I have some reservations about this explanation, but I don't think it's the time to talk about it. When they looked at different categories of hyponatremia for those who on admission had hyponatremia and it persisted, or it was related to decompensation, got resolved during admission, or those who on admission were normonatremic but later had treatment-induced hyponatremia. They looked at these 4 groups in terms of changes in sodium, and what they found is that this treatment-induced hyponatremia, whatever the reason is, does not affect the outcomes. So somebody who has treatment-induced hyponatremia will behave the same way as somebody who has not had any hyponatremia. To this date, I am not 100% sure what the reason is, but we should keep in mind that there is a signal for that. So if I finish here, I haven't given you a balanced talk because I just talked about the advantages of ultrafiltration. Obviously, there are some pitfalls. These are the proposed pitfalls, and I just want to mention one of them. You remember I told you about the higher mass clearance of sodium? I actually went back, looked at the results of CARES heart failure, because CARES had given us every day how much fluid they removed, how much urine the patient had made. There was another study that this was a very small study, 16 patients, that had shown that people who have ultrafiltration, they show a very low urinary sodium. It just kind of counters our removal of sodium. They bring down the urinary sodium. But when we calculate all these, we come to the conclusion that in 4 days, less than 100 millimole is the difference between how much the ultrafiltration will take compared to diuretics. So when we were thinking about major removal of sodium by ultrafiltration compared to diuretics, it's not 100% sure. We really need to do studies to prove that. It remains a hypothesis at this point. Well, when we have small studies that show a little bit of heterogeneity, it's not a bad idea to pull the data and take a look. It's probably the best use of meta-analysis. Here we did a meta-analysis, 7 randomized controlled trials, including more than 770 patients. And these are the details of the studies. I don't go through them, obviously, but the baseline serum creatinine is somewhere around 1.5 to 1.9. We should keep that in mind because sometimes a patient has a creatinine of 3, 3.5, and we are asked to do ultrafiltration. He might benefit from ultrafiltration, that patient, but at least we know that it doesn't fit the picture that we have from the studies. Anyways, these are the endpoints we looked at, and this is what we found. In terms of weight change, ultrafiltration is better than diuretics. It is more efficacious. In terms of fluid removal, again, ultrafiltration is better. In terms of change in creatinine, it doesn't seem that there is any signal of harm or benefit for either of the interventions. In terms of rehospitalization, I know that it doesn't show very well, but it seems there is a tendency for ultrafiltration to do better. It is not surprising because it decongests better. When you come to mortality, there hasn't been shown any difference in mortality. When it comes to adverse effects, it doesn't seem that they are very different. So if you want to remember one slide from the whole talk that I had today, this might be a good candidate. We say ultrafiltration versus medical therapy in acute heart failure. Seems that ultrafiltration is associated with better weight loss and fluid removal, possibly lower heart failure rehospitalization, and obviously more efficient decongestion without a negative impact on renal function. If I want to give practical advice to somebody who wants to do ultrafiltration for heart failure, I would say start early. Caris waited until we had renal dysfunction, then they did ultrafiltration, right? Start early and customize your prescription, obviously. Don't go for flat rate of 200 milliliter per hour for everybody. And then I have used this recently, that objective monitoring, whatever you use in your center, like live monitoring of hematocrit. Use some objective measures, biopsy, for example. And just to show you, this is how they did for ultrafiltration to start with. Based on blood pressure, the rate was changing in avoid heart failure. And these are the guidelines of the societies. I'm not going through them, but they are always a little bit lagging behind with the evidence, obviously. And what is in the pipeline? We are going to wait for pure heart failure trial. That is currently ongoing. There are supposed to be over 800 patients in this trial in Germany and Sweden, and hopefully by the end of March next year, the study will be finished. Probably a few months later, we might have some preliminary data. Let me finish my talk by repeat one of the sayings of Einstein. Diuretics have been in use for decades. If we do them over and over again, hoping that something new will happen to the patient, we might be wrong. We need something new. Whether it is ultrafiltration or not, I'm not sure, but diuretics alone do not seem to be the answer. Thank you very much for your attention.